السلام عليكم، مرحبا بكم في حلقة جديدة من بودكاست أثر يبقى. Today we have my special episode with my mentor, Dr. John Herzenberg. I'd like to thank you for this opportunity, and if you allow me, I'd like to introduce you to my audience. So Dr. John Herzenberg, he's an American orthopedic surgeon specialized in limb deformity correction and limb lengthening and pediatric orthopedic. He trained at Boston University, Duke University, and Hospital for Sick Children in Toronto, and further studied in Elizarov method in Russia and Italy. He held academic positions at the University of Michigan and University of Maryland, and served as a director of an international center for limb lengthening at Sinai Hospital. A former president of the Limb Lengthening and Reconstruction Society, he helped for revive the Ponseti method for clubfoot and co-developed an international magnetic limb lengthening nail. He has authored over 200 scientific papers, major textbooks, and educational apps such as Multiplier and Bone Ninja, and organized the famous annual Baltimore Limb Deformity course. A long-standing humanitarian surgeon, he has volunteered globally for decades and received a POSNA POSNA 2016 Humanitarian Award. Retired from active practice in 2023, he is now emeritus faculty at Sinai Hospital and remain active in teaching, research, publishing, international surfing mission. So, Dr. Heisenberg, how are you today?
Oh, thank you, Dr. Redna. Thank you for that introduction. I'm very fine, thank you. And how's everything in Australia?
It's perfect. Everything is perfect. Everything is perfect. So, today our episode, we want to talk about training, but we want to talk about other aspects in life, work balance, burnout, mentorship, volunteering. I want this episode to shape the human doctor more than the doctor busy in just working. We want to discuss the other aspect in the surgeon life, how to grow, how to learn, these things that we don't learn from books. We actually, it passed to us by our mentors and our senior surgeons and sometimes our colleague also teach us stuff that we cannot find it, as I said, in books. So allow me to start with simple question, then
Sure.
we dig into further question. So first, let me ask you, why orthopedic surgery, especially why pediatric orthopedic surgery, and what early decisions most shaped your career path?
Okay. So I knew in medical school that I was most drawn to surgery. I like doing things with my hand. I like building things, fixing things. And so that appealed to me more than the cognitive aspects of medicine, like internal medicine, for example. So that was a given. And then during the course of my medical school at Boston University, I really didn't have very many mentors, many professors that would actually talk to me and guide me. But I did happen to have one rotation that I did in hand surgery with a hand surgeon who was a general surgeon, not an orthopedic surgeon. His name was J.J. Byrne. He had written a book about hand surgery. And he actually invited me to lunch, and we sat down and we had a nice conversation, which is what, as a mentor, you should do for your mentee. And he wanted to hear about me and what I was interested in. And, just the fact that he met with me and treated me as a human being and showed interest in me, that inspired me. He also asked me to write a paper. He said, "Why don't you?" I didn't even know about publishing or anything like that. I didn't have that kind of uh, information about the medical world, about academic medicine. But he said, "Why don't you tell me about the Esmark bandage? Look up who was Baron Friedrich von Esmark." And so I went to the library and found a copy of Esmark's original book from the 19th century, and I wrote up a 15-page essay about Esmark and his contributions to orthopedic surgery. And then I gave it to him, and he looked at it. He liked it a lot, but he didn't take it the next step. This is where he was a little bit deficient. He didn't take it the next step and said, "Okay, where can we publish this?" So it just kind of sat in a drawer until I was applying for orthopedic residency, and I showed it to my who would eventually become my mentor, Dr. Leonard Goldner at Duke University, and he was the one that said, you should work this into a publication. So then fast forward, an orthopedic resident and then an orthopedic junior attending. And I went on the North American Traveling Fellowship. And that paper that I had written as a medical student, I still had that in my drawer. And when we went to the University of Iowa, Iowa City, they published their own medical journal called the Iowa Orthopedic Journal. And so they asked the North American Traveling Fellows, there were 5 of us, they said, "We'd like each one of you to write an article for our journal." So I said, "Well, I've got this thing that's been in my drawer for a long time, sitting around doing nothing." And so I worked it up into an actual publication. They accepted it, published it. But it all went back to this general surgeon who sat me down and had lunch with me and gave me some advice and had me do a project and actually paid attention to me. And so I never forgot that incident. And as I went through my career, I make a point of having the residents and fellows over our house for dinner, or we go get lunch together. And so you develop a human relationship with your mentee. And that model still sticks with me. And this is now, 50 years later. But that was my introduction into orthopedics through hand surgery.
Mhm.
I then went to I actually, and here's true confessions. I didn't match into orthopedics. Through the match system, I matched into general surgery, and I was disappointed because I really wanted to be an orthopedic surgeon. So I did 2 years of general surgery at Albert Einstein Montefiore Hospital in New York, and then I reapplied for orthopedics outside the match, and that's when I met Dr. Goldner, and I showed him my paper about Baron von Esmark. So it's funny how things happen, but he was very much interested in the Esmark bandage and bloodless surgery and tourniquet surgery, and so he was impressed by that, and we had a good conversation, and he accepted me into the residency program. So something that happened, years prior, just as a result of an offhand remark that my mentor made to me, one of the few mentors I actually had in medical school. When I say mentor, I mean someone who pays attention to you and talks to you and counsels you and gives you life advice and professional advice. So that was how I became an orthopedic surgeon, through first 2 years of general surgery and then 4 years of orthopedics. And then if we take it a step further, I think you also asked Dr. Redna how I got into pediatric orthopedics. Well, I felt that during my residency training at Duke, that pediatrics was the one area that I felt the least comfortable with. And part of that relates to the fact that we had 6 residents every year, and 5 of them went away to the Shriners Hospital where they did only pediatrics for 6 months. And one resident had to stay back at Duke and spend most of the time with Dr. Goldner, who did a lot of pediatrics, but he also did a lot of other surgery too.
Mhm.
So I felt like I was a little bit deficient in peds, and about the time that I was finishing, it was very popular to do a fellowship. It was becoming popular. Now everyone does fellowships. But I said, I really need to improve my pediatric orthopedic skills. So I decided to do a pediatric orthopedic fellowship. I went to Canada for that at the Hospital for Sick Children, and it was a great year, and I loved it. And I just fell in love with operating on kids and treating kids and families, and that was it for me. So um, I'm really happy with my decision. But as a pediatric orthopedist, the way my career developed, I never totally gave up adult orthopedics because my specialty interest became limb lengthening, limb reconstruction. And so while I did a very big practice in pediatrics and cerebral palsy and clubfoot, for example, I even did scoliosis for the first 5 years of my career. Um, I I developed a real specialty interest in limb lengthening, and that covers both pediatric and adult. So throughout my professional career, even though I'm a pediatric orthopedist, when I look in the mirror, I see a pediatric orthopedist. I really enjoy taking care of my adult patients, patients with non-unions, malunions, osteomyelitis, the typical sort of Ilizarov type patients that we see. So I've really enjoyed both ends of the spectrum. I enjoy the fact that as an orthopedic surgeon and a pediatric orthopedist, I get to operate on the hands, the arms, the shoulders, the feet, the hips. And as a universalist, I get to operate on both children and adults. So it's just worked out really well for me. I really enjoyed my career choices. They worked out well.
Perfect. Perfect. Okay. For trainees, deciding between general orthopedic practice and pediatric orthopedic, what factors should they weigh? Because in our country, they finish the board and they have the choice to stay as a general orthopedic for 3 years and become a consultant in general orthopedic, or they take the other path in fellowship. As you said, nowadays fellowship is more popular, but still others choose to do the general orthopedic. So for trainee, deciding between general or subspecialty, what factors should they weigh?
Well, I'll give you some advice that my mother-in-law always gave us. She said, do what makes you feel good, do what you like. And so if you're particularly drawn to foot surgery or hand surgery or spine surgery or joint replacement or sports medicine or pediatrics, I mean, whatever you are most drawn towards. By the same token, I think that we should all be generalists to a certain degree. We should all be comfortable doing trauma, for example. So when
Yeah.
you're in a group, you can take trauma call. And so I think it's a mistake to paint yourself into a tight little corner and say, I'm only going to be doing club feet, and oh, by the way, only left club feet, not right club feet. So you really want to, I think it's a good idea to have a specialty, but also a subspecialty. And so what do I mean by that? When I think back to my first job, my first position after I finished my fellowship, I went to the University of Michigan. And the reason I went there is because I knew I would get very good mentorship from Bob Hensinger. He's a very famous pediatric orthopedist. He's been president of the Scoliosis Research Society, the POSNA, the Academy, American Academy of Orthopedic Surgeons, and also he was editor of JPO, still editor of Journal of Pediatric Orthopedics. And so this was a man who I could really train under and would help me. He's very experienced and is very kind and giving of his time. And so I chose that as my first job. But I'll never forget that the first week that I arrived in Ann Arbor, Michigan, Dr. Hensiger sat me down and he said, "Okay, John, so what's your specialty going to be? What are you going to do?" And I said, "Well, I'm a pediatric orthopedist. Isn't that enough?" And he says, No, that's not enough. You also have to have an area of expertise, special interest, that, you, in addition to pediatric orthopedics or within pediatric orthopedics, that you develop a special expertise interest, and patients will seek you from all over because you're the expert in X, Y, or Z. So I had done a lot of club foot surgery when I was a fellow in Toronto. Norris Carroll was my mentor, and I enjoyed club foot surgery, but I also felt that, and I learned a lot of club foot surgery during my residency because Dr. Goldner was a club foot expert. But I also felt, and I was totally wrong on this, I felt that everything that could be learned about clubfoot or could be done had already been done. There was like nothing more to
Mm.
discover. It was a dead end in terms of academic endeavors, doing research projects. I just didn't think it was anything left to discover. I thought that the clubfoot had been figured out and it's no longer a intellectual exercise. Well, I was totally wrong about that because 10 years later, the Ponseti method came out and it totally changed what I was doing. I became a promoter of the Ponseti technique, but at the time, I didn't have the common sense to realize that I was wrong on this. But around the same time, the Ilizarov method was just coming into play. There were just a few doctors in Italy doing it. Dror Paley had just gone over to Italy to learn how to do it, and I had met him in Toronto. So I knew about the Ilizarov method. And so I said, aha, this is something interesting because during my fellowship in Toronto at the Sick Kids Hospital, I'd only seen in my entire fellowship year one or maybe two limb lengthening cases. And
Okay.
yet, fast forward to me being in practice, we do them every week. So this really was an area that was ripe for development. There was, not enough good information about it, not enough experience on it. People weren't doing it. And so I settled in very early on being a subspecialist in Ilizarov surgery. Now I didn't give up the other stuff. I still did pediatric orthopedics. I still took trauma call. In fact, the first 2 years that I was in practice in Ann Arbor, Michigan, we didn't have a musculoskeletal oncologist like that's what you're doing now, Doreen, right? You're doing a
Mhm.
fellowship in Adelaide and MSK surgery. We didn't have someone like that, so I was doing adult tumors. I remember doing four-quarter amputations and big tumor resections, and I was doing big spine cases. So
Mhm.
you start out doing a lot, but then you kind of shrink down to doing the areas that you're most interested in. But getting back to the original question, how do you decide? You do what makes you feel good. Do it, as my mother-in-law always says, do what you like. And if you do what you like what you do, you'll have a happy life. Some people don't make that decision. Some people make the decision based on finances. They say, well, as a spine surgeon, I can really make a lot of money.
Mhm.
And I like peds and I like kids, but they don't make that much money. So I would tend to base my decision making or recommend that you decide what you're going to do based on what really makes you happy and what you get the most satisfaction from. And also don't paint yourself into a little corner, at least early on in your career.
Okay. Okay. So, the next question, which experiences during residency or fellowship provide the greatest long-term value for your practice and academic work?
Well, I think it's really important that you have good mentors and good role models. Because the way we train in orthopedics and in all specialties, really in surgical specialties, it's a kind of an apprenticeship. Like you want to be a blacksmith, you go, you study with another blacksmith. You want to be a carpenter, you study with another carpenter. And that's basically what we are, right? We're carpenters or blacksmiths. And so you have to have good, you choose a program that's well-rounded, that has good surgeons, as your teachers. And what I found is that in life in general, you can always learn something from anybody. I'll give you an example. When I was a resident, we had one attending who used to really give us a hard time. He used to, just ride us really hard and ask us hard questions and basically tell us we're dumb if we didn't know the answer. And nobody liked working with him because he just wasn't pleasant to work with. He was a very sort of mean guy. But this guy, and I won't say his name, but this guy, as a resident, he let you do the surgeries. Whereas many other attendings, they would do the surgery, and as a resident, you were only assisting. So I was willing to put up with all the CRAP that this guy would shovel at me because I got to do all of his surgeries. And
Mhm.
so I really improved my surgical experience. So that's an example of kind of a guy who, he wasn't a good mentor or role model, but I got a lot from him. I got a lot out of working from him. So I think as you go through life, you meet people, in your personal life, in your professional life, there's always something you can learn or get out of somebody. Nobody's, without any value. So you just
Yes,
have
I
to
agree.
figure out what their superpower is and how it can help yours.
So I have a question, a simple one, but I always thought about this. What make a surgeon good mentor?
Okay. Well, that's a great question. I mean, having been in academic orthopedics my whole career, I've literally had hundreds of residents, fellows, medical students, rotate with me, and really should ask them, was Dr. Herzenberg a good mentor or not? I remember when you were with us in 2019 as a visiting resident, you were always asking questions. You had a notebook that you took, wrote everything down on. So you were a good mentee. You got to be a good mentee and you got to be a good mentor. As a mentor, I think the most important thing is you have to respect your mentee, give them time, give them of yourself, um, and you have to take pride and pleasure in your mentee developing skills. So for example, I've trained now a lot of fellows, dozens of fellows, and some of them, I'm happy to say, many of them have surpassed me academically, surgically, technically, and I have great pride in that. I'm not jealous. I'm not. In fact, I have one particular young lady who came as a fellow, and even as a fellow, I felt that her technical surgical skills were better than mine. Now, she didn't have my experience and my breadth of, work, and my, there's something that comes with being a doctor for a long time and having experience, but technically she was superb. And it as a surgeon when you see another surgeon operate, you know who's good and who's average. Some guys who just sort of fumble along, and other guys, my mentor when I was a fellow at Sick Kids in Toronto was Norris Carroll, and he used to do clubfoot surgery, very open clubfoot surgery, posterior medial release, and he would sit bolt upright in the chair, and only his hands would move. When I operate, I'm looking around, I'm going up and down, I'm just getting off the chair. He would sit there, and you only see his hands moving, and he never wore loops, just wore his regular glasses. And he was absolutely technically the best surgeon I've ever witnessed operate. It was very inspiring. I mean, I don't think I'll ever be as technically adept as he was, but it's a good role model, and I tried to emulate him for that. Um, so it doesn't matter if it's a guy. Well, as a mentor, it's really important that you pay attention to your mentee, you give them time, because that's where the learning and the knowledge transfer takes place. And I'm just going to take it one step further, Dr. Redna. One of my colleagues, who was a Vince Mosca, a very well-known foot surgeon, pediatric foot surgeon, he and I were residents together at Duke. And now he and I are both retired. We're both recently retired. And Vince had a saying. The saying was master, mentor, and move over. The three M's. I'll repeat it for the
Yeah.
residents. Master, you master your craft, become good at what you do. Then you mentor your junior people and eventually your replacement. And then once you've mentored up somebody, then you have to move over and step down, make room for the junior people because they need to advance their career as well.
Yeah.
Um, so I think it's very important that the different stages of your career that you recognize that, none of us live forever, none of us are going to be around forever. And so our goal is to teach the next generation so they take over and hopefully they will surpass us. And, hopefully they'll credit us, that just like Isaac Newton said that, what was his famous quote? That if he saw really far, it's only because he was standing on the shoulders of giants. So I'm hopefully my mentees who are now, better than I am and doing wonderful things. I was their initial source of inspiration and knowledge, but they surpassed me, and that I take great pleasure and great pride in seeing my mentees being successful and being really, famous and publishing and teaching and writing books and things. That's great.
Yeah, perfect. So, how did you choose your first attending job? And the second part of the question, what advice do you have for negotiating that first contract?
Um, so when I was looking for a job, of course, you see what are the options, who's advertising, who needs help. And in my case, it came down to one of two places. It was three, but eventually it came down to two. It was either University of Michigan in Ann Arbor, or it was going to be the Shriners Hospital in Tampa, Florida, which is now closed, by the way. Um, and I did a side-to-side comparison of who was going to be my boss, my mentor at both places. And at Michigan, it was Bob Hensinger, who I mentioned, and he's a great guy, editor of JPO, president of any organization you can think of, very experienced guy and very caring, wonderful man. At the other place, it was a more controversial guy who had written a very famous book. His name was John Ogden. He'd written a famous book on pediatric fractures, but there was just something really odd about him. And so I made my decision. I mean, it could have been, with palm trees and Tampa, Florida, and, nice year-round weather. When I went for my interview in Michigan, it was ice cold, freezing, snow. Um, I went for actually two interviews. On the second interview, my wife came with me, and she was 8 months pregnant, and she couldn't even close her coat, and it was freezing. And then the rental car that we got to drive to Ann Arbor didn't work because the locks were frozen shut by the ice. So she said, "Let's go to Tampa. It sounds a lot better." But in the end, I made the decision based on where I thought I would have better mentorship. Because just because you finish your training, your residency, your fellowship, it doesn't mean that's the end of your training. You're still learning. I mean, you're going to be entering very soon, I guess, Dr. Redna, when you finish your musculoskeletal oncology fellowship. Uh, but it's still helpful to have. My advice to you would be to pick a place where there's someone very experienced that can help you work through the difficult cases, scrub with you, and eventually you mature and you develop, and then you become that person and replace that person.
Hmm. Okay.
So that is the general advice. You also asked about negotiating a contract, and I must say
Yes.
that the that was the second part of your question. That for most doctors, we're so happy that we're most junior doctors who just finished their residency or their fellowship. We're so happy that someone is actually going to pay us to do what we like. That we accept things without necessarily thinking about it. So I would say you always end up doing better on your second contract than on your first one. On the first one,
Okay.
you just sort of, they say, here's your contract, and you sign on the dotted line. If you're a little more clever, you'll ask some questions, but you don't want to offend anybody. But my experience is that everyone does better on their second contract than their first. But the ideal situation is you only have one contract. What do I
Okay.
mean by that? The ideal situation is you find a job where that's where you start your career and that's where you end your career. Now, that did not work out for me. I started in Michigan for 5 years, and then I went to the University of Maryland for 10 years, and then to Sinai Hospital for 22 years. But if I contrast that with my buddy, Dr. Mosca, he went from his fellowship to the University of Washington State, Seattle Children's Hospital, and Lynn Stahaley was his mentor, also another editor of JPO, very great guy. And he spent his entire career at that one hospital. He didn't jump from job to job or from state to state. Vince went to one hospital and did his entire life career in that one hospital. And the advantage of that is that you maintain contact with all your patients. Every time you move from one job to another, you lose some of your patients. It's
Yeah,
hard to get the records for research purposes. And so I'm not, if you get in a bad situation, you shouldn't, just ride it into the ground. You should change. But if you are, the ideal situation, in my opinion, is one job and you stick with that for your whole career.
perfect. Okay, so let's talk about clinical skills. What clinical skills or procedure do you recommend young surgeons master early in their careers?
Um, that's a great question. I think the biggest mistake that I see young surgeons making is that, and this kind of sounds funny, but they don't operate enough. Especially if you're in a teaching hospital and you're a junior attending, um, you have residents and maybe fellows, and the residents need to learn how to do surgery. So part of what you're doing is teaching the residents. And just as I told you about that one guy that we had at Duke University that was not very nice to us, but he let me do all of his surgery. So I loved him. I mean, even though he was really mean and nasty, I loved working with him because I get to do so much surgery. But he was a very seasoned senior surgeon, and that wasn't the issue. But when you're a junior surgeon, when you're a young attending, assistant professor, instructor, then it's really important that you establish your own surgical skills, and that's more important than the residents. The residents can learn from the more senior people in the group. Um, so I think the biggest mistake I see is there are some surgeons who give away the surgery. You know what I mean by giving away? They let the resident do the whole case when they themselves haven't yet become masters of their craft. So you need to master your craft first before you can start to give away, let the residents. Now, it doesn't mean you can't let them, close the wound, but if they're closing the wound, you should be there while they close. So make sure they're doing it the way you want them to do it and they're doing it
Right.
correctly. Maybe you give away certain parts of the operation. But throughout my career, I've met surgeons who, and this sounds really strange, but there are some surgeons who don't like to operate. I think they chose the wrong profession. They got pushed into surgery. They thought they liked surgery. They've invested so much time in it through their residency that but then when it comes down to it, there are some people who just don't like operating. And they typically have the residents do all of their surgery, and they
Yes.
are kind of supervising. Um, to me, that's kind of sad. To me, that means that you made the wrong career decision, or you couldn't change, gears when you made the bad decision, and you just rode it in and rode that single path all the way down. And so I guess the most best advice I have for the young surgeon is master your craft before you turn it over to the residents. That may
Mm,
not make you the most popular uh, teacher in the program, but at least for a couple of years, you got to be a little bit stingy about what you give away to the residents.
okay. 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 How should young surgeons balance building clinical competency and developing research and academic credentials?
Okay. Well, so there are many different pathways. I know surgeons who are great clinicians, but they're not paper writers or chapter writers or book writers. They can't do that. It's not in their interest or their skill set. And so you don't have to do everything. If you really love operating and taking care of patients, but it's painful for you to sit down and write a paper or to edit a paper, then you don't have to do it. I think it's something that you should do once or twice as a resident, and most residency programs do require you to write a paper,
Yes.
do some kind of research project. So it's important to get the feel for it. Just like a residency program makes you do spine surgery and hip surgery and knee surgery and sports and foot surgery and hand surgery and pediatrics, even if you're going to become a spine surgeon. You do have to get some familiarity with the orthopedic field and our what we do, but it doesn't mean that everybody has to. And so if you don't have that particular proclivity, if that's not your thing, then there's no sense forcing yourself to do that. But I look at myself. I enjoy teaching. I enjoy research. I enjoy publishing. I think it's more of an ego trip than anything else. We like to see our name in lights, or be on the podium speaking, giving talks. Um, but I'll relate it to my own career where I did all of it. But I made a few mistakes, and one of the mistakes I made was that I would write a paper, or I would do a research project, and then go to a meeting and present it. So I'll give you an example. I wrote one of the first papers I ever wrote was about CT of tarsal coalition. I mean, there was at the time CT was new. That's how old I am. And tarsal coalition wasn't well understood, particularly talocalcaneal coalitions. They're hard to visualize. And so I had a nice paper that I put together, and I presented it at the Foot Society. I presented it at the American Academy of Orthopedic Surgeons. I presented it at the Maryland Orthopedic Society and at the pediatric meetings. So the same paper I dragged to like 4 different meetings. And then when I got back home from all this travel, because I was traveling a lot, I was started on some other project. I kind of lost interest and never wrote it up for publication. Now, eventually I did and got it published, but it would have been better if I presented it at one meeting or maybe two and then wrote it up for publication. Because here's the difference between presenting a paper at a meeting versus writing a paper and publishing it. When
Okay.
you when you give a paper at a meeting, your PowerPoint, you as soon as the words leave your mouth, they're gone forever. And no one can look it up easily or refer to it. On the other hand, if you publish a paper in a journal, especially now that everything's electronically available through PubMed, and I would only publish in PubMed journals, not the ones that are not listed in PubMed. But when you publish something, it's there forever. So my biggest mistake in my career was spending too much time on the road traveling and presenting my papers and not enough time writing them. Now, I ended up writing enough papers, I guess. I'm up to about 200 papers, and since it's been 40 years since I finished my residency, that comes out to be about 5 papers per year, which is, respectable. It's not, there's certainly people who do more than that, but I've been very happy with the amount of publishing I did. But I would have had even more papers had I been a little bit more focused on publishing them rather than presenting them at multiple meetings.
Okay. Perfect.
The other
Perfect.
part of balance, though, which is even more important than that, is balancing your work life with your home life. And that's
Okay.
something that we don't do a very good job of, frankly. And, you know, if I look back at my own career, if you were to ask me, would you do anything differently? And I probably would say that I would spend, less time traveling and away from the family and more time home. Um,
Okay.
I, in my career, I've been to Japan, I think 12 times. I've been to China several times. I've been to Korea a few times. I've been to Europe, been Saudi Arabia, been to Egypt many times. But your kids, your children, they don't understand that daddy's, lecturing in Jeddah to the Saudi Orthopedic Association. They could care less about that. They only know that daddy's not home.
Yeah.
So while for me it was a great honor to visit Saudi Arabia or Japan or fill in the blanks, it does take a toll on the family life. And so I don't know how many of the young people are in the audience now, but if you remember nothing else from what I said, please, please, please prioritize your family. In the end, when you get old and decrepit and you're sick and you're in your deathbed, um, it's only the family that's going to be there for you, not your colleagues, not your friends, it's your family. And so you really have to
Okay.
nurture those relationships. Um, they're the most important ones. So take it for what it's worth, but that's advice from an old guy.
I totally agree with it. So, in your opinion, what strategies do you recommend for finding and nourishing mentors?
Uh, so when you're a young uh, attending or a resident, I mean, when you're a resident, you have a group of mentors to select from in your program.
Yes.
So you have to find someone who you're compatible with. Um, for example, as a woman, you've probably faced special challenges as a woman orthopedic surgeon. There's probably not too many in the kingdom. Um, so if there's another woman on the staff who you can pick as your mentor, she'll have more insight into the challenges and the solutions that you're going to have to reach as a woman in orthopedic surgery. It's becoming less of an issue in the United States now where it's almost 50-50. Certainly in pediatric orthopedics, it's 50-50. Um, but it's kind of like being married to someone. So you have to be compatible with your mentors. So they have to have a similar personality. You have to get along. You have to, they have to be committed to you, and you have to be committed to them. So that means having regular meetings.
Uh-huh.
That means writing things down and discussing things. That means working on projects together.
Okay.
So it's kind of we talk about your regular spouse and then your work spouse. You know, you have
Mhm.
someone at work who you're working closely with, and so you need to be compatible. So you have to get along. That's the most important thing. And when you're picking a mentor, pick someone who is not so egotistical that they only think about themselves. They have to take pride in the fact that they're mentoring a young person and take pride in their accomplishments, just like you would take pride in your children and their accomplishments. I mean, in many ways, I look at my, fellows as my children. And
Mhm.
then just like my own children now are in their, 40s and they have families and their own children. And I have great pride in the fact that they're great parents and they're doing a good job raising their kids and they're successful professionally. So that's what you want to seek in a mentor. You want someone who has a true interest in your well-being.
Yes. Yes. So, uh, just what you said, it resonates with me. Choosing a mentor, it's very difficult, but when you find the one, life become more easy. Facing complication become more easy. Learning become more easy. Mhm.
And Doreen, you have many mentors. There's your main mentor at work, but then you have mentors that you worked with in the past. I mean, I think that we have that relationship that
Yes.
ever since you were with us in 2019, we've stayed in touch. I followed your progress in your career and here and there giving you advice. So you don't have to have only one mentor. You can have several mentors, and one mentor may be for life issues, another mentor more for professional issues. So it's actually a good thing to have more than one mentor.
Okay. Okay. So, how did you structure your early academic productivity, publication, presentation, and what would you do differently?
Um, well, I think I answered that a little bit, in that when I look back at my
And
career, I
yeah.
did a lot of presenting at meetings and traveling to meetings to present a podium paper, and not enough staying at home and writing it up and getting it published. I mean, I'm ashamed to admit it, but I've got some papers that sat in the drawer for like a decade or more. And then finally, I felt so bad about it that I would take some medical student or junior resident and say, here's a paper that I wrote 10 years ago, it just needs to be updated, and put a stamp
Mhm.
on it and send it to the journal of whatever. Um, so that you know, you have to, I think you have to really, if you want an academic career, you want to put more of an emphasis on publication than on presentation. You have to do both, but you want to have some podium presence and you're trying to build your reputation. But the best way to do that, I think, is by publishing.
Okay, let's go back again about young surgeons. How can a young surgeon develop good judgment and decision making under pressure? Any specific training or habits?
Okay. Um, so I have a couple things. First thing, there's a great book that I think all junior attendings or residents and fellows should have. It's called Skill, 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 and it's written by Chris Ahmed, Ahmed. Chris Ahmed is a sports medicine specialist at Columbia University, and it's a small book. It's very inexpensive. It's like $15 on Amazon, but it's got about 40 chapters, and each chapter is only 2 or 3 pages long. But it's 40 things that you can do to become better at your craft. You know, how do I become a better surgeon, a better orthopedic surgeon? And because this is a book that's written by an orthopedic surgeon, it's easy for us to relate to. But he also brings in many lessons from the world of sports, because he is a sports medicine doctor, and from the world of chess, because his son plays competitive chess. So, for example, if you look at young chess players, when they're in a tournament, they write down every move that they did on a piece of paper. And then at the end, you know, they either win or they lose, doesn't matter. But at the end, you sit down with your coach and you go through the game and you say, all right, at this point in the middle of the game, you did knight to king four. Why did you do that? What were you thinking? If you're a football player, they take a video of the whole game. And then the day after the game, you sit down with the coaches and all the players in a room and they watch the game files. And they stop and start and they dissect every little piece of the game and say, all right, here you did this. You decided to pivot to the right, but if you had pivoted to the left, you would have had a wide open space that you could have run to. So we don't do that as much as we should do in orthopedics. We have a check-in list before surgery where we review things, and we theoretically have a check-out list, but we're not as good as doing that as, say, pilots are, or basketball players, or football players, or chess players. So ideally, you should, at the end of every case, review everything you did. Now, that's just like one chapter. One other chapter is keeping a notebook. Everyone should keep a notebook where you have a list of all your procedures and what you did and what you learned. And if you go to a lecture, you should keep notes. And you look at the best note taker in the world ever was Leonardo da Vinci. He did folio after folio of notes, and only about 25% of what he wrote is still existing. The rest are, destroyed or lost. Um, but he made just little observations of nature, watching a woodpecker go against the tree with his head, and then trying to figure out, well, how does he do that with his head and not cause trauma? And then he would
Mhm.
dissect the woodpecker. So anything that gathered his interest, he would write down and draw little pictures in his notebook. And I recommend for all my fellows, in the first day of their fellowship, I give them a notebook. They can use their own notebook, but they give them a notebook and say, here. And then every few weeks we sit down and see what you've written down, and what you've learned. So if you just listen to something that goes in one ear and out the other, But if you take the time to write it down and then review it, then it tends to stick. So it's just another, so notebook and coach, visualizing the game ahead of time. So the guys who drive in the Tour de France, they know every bump and every crack in the road of every stage of the tour because they've gone over it so many times. There's no surprises. They know where the turn is. They know what they're going to do. They know what their strategy is going to be. So then when it comes to race day and they're actually doing that leg of the event, it's like they've done it like 20 times already. And some of those times are just in their head. So I do that even now. So especially now that I'm retired and I'm not operating that much, when I do go away every 3 or 4 months to operate in Nepal or Honduras or Ukraine, I make a point of the night before the surgery of going through every step in my head, step one, step two, step three, and then writing it down on a notebook. And then sometimes I'll bring that in and I'll have my notes and I'll hang it up on the wall. And just to make sure that, did we do all the steps? Did we forget anything? Sometimes you have a multi-step operation and you forgot to do the fibular osteotomy or you forgot to do, the XYZ. So preparation is really good. And even if you're not actually, as a basketball player, for example, doing the actual layup, you can just sit in a chair and visualize yourself doing it. So you don't have to actually do the surgery 20 times before you go to the operating room, but you could do it in your head. You could look through the anatomy books, and in many cases, sometimes you even go to the anatomy lab and do a dissection if it's some new operation that you're not familiar with. So there's lots of little lessons, and so the best advice I can give to the young people is to go on Amazon, buy Chris Ahmed's book, Skill. It's easy, small, inexpensive, but gives you lots of practical tips on mentorship and how to become better at your craft.
Perfect. Okay. How should a surgeon approach work-life balance and prevent burnout, especially during fellowship and early practice?
Yeah, that's a really important question and one that we all, many of us anyway, get wrong. And so I think we have to recognize that we're humans, that we have needs outside of our professional lives, that our families have needs. But unfortunately, there's a culture of, I call it postponement in medicine, and not just in orthopedic surgery or pediatrics, but in medicine in general. And what does postponement mean? And this has been studied by psychologists. When you're in college or when you're in medical school, start with medical school, and let's assume that you're married, so you have a wife or a husband. So you tell your spouse that I'm really busy, I've got to just get through this exams and through my degree in medicine, but once we do that, then everything will be better. And then the next thing that comes at life is your residency. And now your spouse, you hardly see your spouse. You're at work all the time. You're working or going in early, coming home late. When you're home, you've got to work on, read for the next day. And then you're tired all the time. But you tell your spouse, don't worry. Once I just finish my residency, everything will be fine. And then you do a fellowship, and it's more of the same. And your spouse hears it again, that, oh, it's just because I'm a fellow now, but once I finish my fellowship and I'm a real doctor, then I'll have more time. So we keep on postponing, year after year, stage after stage in our career, we postpone this. And then you find when you start your practice, like there's all these demands on you. You have to take call, you have to build your practice, you're trying to get your numbers up. And so you tell your poor, long-suffering spouse that, yes, honey, it's fine, but I just need to get my practice started, and once I do that, then we'll have time. But how many times can you say that to your long-suffering spouse before the spouse, says, this isn't worth it, and then all of a sudden you find yourself divorced, and then your life falls apart. So the way you avoid that is by thinking about it and by recognizing and by setting limits. So, and learning how to say no. So if you're really busy as a resident, for example, and they come to you and they say, well, we'd like you to become the chief resident because, you're so good and organized. But you realize that by becoming the chief resident, or the resident in charge of X, Y, or Z, that you're going to have to spend more time doing that. And you just don't have that time because you've got a young family at home. So you have to not be so much of a people pleaser, but really protect yourself. Draw, borders, set limits, and say, "I'd love to do it. Thank you. I appreciate that." And it's going to happen throughout your life. You're going to be a junior attending, and someone from the medical staff office is going to approach you and say, "Dr. Redna, we'd like you to be the chairman of the infectious disease committee in the hospital, or, the, the CME committee or something like that." But you're already overextended and busy.
Yeah.
So, a lot of us are what I call people pleasers, where we don't like to say no. We like to be nice to people, and so we tend to say yes all the time. But let me tell you, as someone who spent his whole life saying yes, it's very liberating to say no. If someone asks you, "Hey, will you come on, this trip, or would you come and do this, or come be a visiting professor?" And if it's not the right thing for your family and for your career, your family, you shouldn't accept it. So I have one friend who used to
Mm-hmm.
say that every time you get an invitation to go give a lecture, to run a course, to teach at a course, ask yourself two questions. Question number one is, well, before you say yes I will or no I won't. Question one is, what is it going to do for my career? Is this really going to advance my career? Do I need this to advance my career, to get tenure or whatever? So question one, what is it going to do for my career? Question number two, what is it going to do to my family?
Oh,
So only after you consider both of those questions, is this really worth it? Is this going to help you professionally? Or are you just doing a favor to your friend who's inviting you? So if it's not really going to help you professionally, if it's going to not be good for your family for you to be off for 5 days at because Dr. Herzenberg invited you to come to speak at the Baltimore Limb Deformity course, then say no. It's very liberating to say no, and the person who's asking you won't hate you. They'll if they like you enough to ask you, they'll ask you again. So, I turn invitations down all the time now, and I say that I thank you, I love it. I've got some other stuff going on now, and people understand. Or my daughter's going to have a baby, and I have to be around town to see my grandchild being born. I can't be away that month.
yeah.
People understand. So there's the power and the liberating effect of saying no. It's very it's a skill that we all need to learn.
Yeah. I think it's very important skill to be so for someone to learn. Okay. How important is involvement in professional societies, and how should a young surgeon engage with them effectively?
Well, I think it's important to be involved in a few professional societies, but not too many. I give you an example. When I was coming up in my career early, I was a member of POSNA. I was a member of AAOS. I was a member of the Maryland Orthopedic Society, the Michigan Orthopedic Society. We had the Duke Orthopedic Society, where my residency was. And then I became a member of the ORS, the Orthopedic Research Society. I was a member of the Scoliosis Research Society. I mean, I think that's too many. You should just pick two or three societies, focus on those, and you don't have to be, just because you're doing research doesn't mean you have to present at ORS. You can present it at the Academy or Posner or whatever. You don't have to present it at, 5 or 6 different meetings. So I think you should be very judicious about your time and how you allocate your time, because On the one hand, it's an honor to be a member of a society, but usually it's not that big an honor. It's just you paid the dues and you filled out an application. So, you don't get that much out of it. And there are some societies that I joined and then I left. I was a member of the Orthopedic Research Society, and I stopped going to the meetings. It was tedious for me, and so I left. I was a member of a travel club. Um, that after a few years, I said, I just don't need this. I'm presenting the same paper I'm presenting at other meetings just to have a little social meeting with a bunch of guys. What's the point? So don't extend yourself too thin. Remember, Dr. Redna, no one ever wrote on their tombstone as their epitaph, I wish I had spent more time in the office.
Yeah.
No one ever says that. It's just the opposite. It's, I wish I would have spent more time at home. So,
Yes. Okay. How do you stay current with the evolving techniques and technologies like 3D printing, and what should new surgeon prioritize learning?
yeah, I think it's important, especially for the new surgeon, to develop some tricks, some special skills that they have. As an older retired surgeon, do I want to learn how to do 3D printing osteotomies? No, but I appreciate the young guys who are doing it and they're making templates and doing their osteotomies. But I also am happy to say, well, that's fine. But now when I'm operating in Nepal or in Honduras, they don't have a 3D printer. They don't have the
Yeah.
CT scans. And so I take some pride in knowing that I'm a surgeon and I can do an osteotomy without a 3D printed guide. Now, any young person who wants to make their name in orthopedics, I say go for it. If you want to do 3D printing and learn how to do osteotomies that way and make yourself a name, then I would say go for it, do it, and do it for everything. And that's essentially what I did. If I look back at my career, how I became an Ilazarov surgeon, it's important to get a lot of cases under your belt that you've done in order to become an expert. So when I decided that I was going to make Ilazarov the focus of my career, well, one of the focuses, I started using it for everything. Maybe overusing it even a little bit, but I could always justify it. So, for example, any tibia fracture that needed surgery in a child, I would put an Ilazarov frame on in the early years. I wouldn't do flexible nails or a plate, or you could do any number of things. You can choose many things. Even femur fractures I treated with an X-Fix. Now, once I have a lot of experience in it, I'm very good at it, then I don't feel like I need to do so many of that particular case, and I can just focus on the cases that really need it. Bone transport or lengthening or angular correction or something. But early on, I overused it a little bit. But by doing that, within 1 year, I did 50 cases. And so I got a lot of experience that became very facile with the equipment. And so I got very good at it. There are some osteotomies that, for example, you brought up the idea of 3D printing templates and cutting guides. There's some things that you don't really need that for. You could just do an osteotomy, an open wedge, and put a graft in. But if you want to gain experience and expertise, make the 3D printing guide, go through the exercise. It's nice with the people who are doing that. I really admire it because they do the surgery on a computer, then they build the template, then they do
Mm-hmm.
the surgery on a sawbone, and then they go to the OR and do the surgery on the patient. So by the time they get to the patient, they've already done the surgery twice before on the computer and on the sawbone. So I have a lot of respect for that. And so I would say if you're going to do it, embrace it, do it all the way, really focus on it and get your expertise. And then later on, you can say, okay, we don't really need it for the simple HDO, but I can use it for this complex multiplanar, multi-level osteotomy.
Yes. Yes, I agree with you. So, what role does global health or international collaboration play in your work? And do you recommend early career surgeons pursue such opportunities?
Um, yeah, so great question. global health or international outreach has been an important part of my career starting around age 40, 42. I think was my first trip. I went to Nicaragua. I was invited by a friend. Before that, I think there's nothing wrong with doing a trip or joining a trip when you're a resident or a fellow. I, on all my trips now, I take a fellow with me. And I think it's important that they get the experience of that. That's a good thing under your belt. You get to see cases that you don't see back home. When you go to a place like Honduras or Nepal, you see natural history cases are never treated. And so, it's one thing to treat a newborn with a clubfoot. It's another thing to treat a 20-year-old with a clubfoot who's never had any treatment. It's much
Mm-hmm.
more challenging. So I think there's a lot to be learned. But I think probably, when you're going as a surgeon on one of these trips and not as an assistant or a helper, it's probably better that you have more experience under your belt. And so I wouldn't make it a part of my career early on. I think it's just something you do when you're a little bit more mature and you have more skill, experience, and judgment, and you can bring more to the table that way. I mean, but I think by all means, if someone calls you up and says, Doreen, yeah, I'm going to Nepal in April, and would you like to join me? Say yes, because if you have the time, you have to always ask those questions. What's it going to do to my career, and what's it going to do for my family?
My family.
Um, but yeah, I think it's a great experience for a young person once or twice. A lot of medical students do it, a lot of residents do it, some even pre-med students do it. But I think in terms of a real making a donation to the to the developing world, it's better if you go when you're mid-career, not early career.
Okay. Can you share a case or teaching moment early in your career that shaped how you approach patient care today?
Um, well, yes, uh, but this is in the category of true confessions. This is something I'm not proud of, but it was a real teaching moment.
Okay.
So I'll go back to you. You said when I was a resident. Okay, so when I was a chief resident, my last year of residency, where we didn't have to take call in the hospital, we were allowed to take call at home.
Yes.
But we had a junior resident who was in the hospital in the ER. So one night, the junior resident calls me up and says, "Dr. H, I got a elderly woman who fell, and she has some hip pain, and she hurts a little bit when I move her, but I got X-rays and I don't see a fracture." And I showed it to he tells me I showed it to the radiologist, the radiology resident. He doesn't see a fracture either. And so I said, well, okay, so if there's no fracture, you can, just give her a walker or crutches and let her go home. And that was in the era before we had electronic transfer of X-rays. So I wasn't able to see the X-ray. Now, of
Yes.
course, I think the thing to do is the resident might take a picture with his phone and send it to you, or you would log on to the PACS and look at it from home. But imagine yourself before PACS. There was no PACS. It was just hard copy X-rays. There was no iPhones, believe it or not, when I was a resident. Um, so I just believed what the junior resident told me. I said, well, he looked at it, he showed it to the radiology resident, and they didn't see a fracture. So the next morning, I get a call from Dr. Goldner, the chief of the department, my chief, the head of our department. He says, John, come down to the office. I want to talk to you. So, uh-oh. So I went down to his office, and he says, did you see this, did the patient come in last night, this elderly woman with a hip pain after she fell? I said, yeah, and the resident told me he saw the X-ray, he showed it to the radiologist, there was no fracture. He said, well, that patient is my next door neighbor. And I looked at the X-ray, and here I have it right here. Will you take a look at this X-ray? And sure enough, there was a non-displaced fracture of the femoral neck that the resident had
Mm.
missed, the orthopedic resident missed, the radiology resident missed it. But had I gone in to see the patient, looked at the X-ray, I would have seen it. So at that point, I felt I was about this tall, and I was waiting for him to fire me, but instead it was a teachable moment. It was a moment of, what I did versus what I should have done. What I should have done
Yes.
is gotten out of bed, gone into the hospital, looked at the patient, examined the patient for physical signs, which she had, and also looked at the X-ray. So I never, I mean, that was 50 years ago, and yet I still haven't forgotten that story, and so it still rings true with me. A similar, somewhat related story is when I was a intern at Albert Einstein Hospital in the Bronx, and I was on a neurosurgery rotation, actually a pediatric neurosurgery rotation. And I was assigned to a senior neurosurgery resident, and he wouldn't let me do anything. We were doing a lot of shunts and tapping shunts and things, and so a kid would come in with an infected shunt, and I say, "Well, can I do this one? Can I tap this one?" He says, "No, no, I'm going to do it." Okay, so he told me his philosophy in life, and it sounds very cynical, but his philosophy as this neurosurgery resident was everyone above you is a liar, and everyone below you is an idiot, and that's how he approached life. And so I thought that was very cynical, but I still remember it that the people above you can't necessarily believe them, and the people below you can't trust them. So you just got to do everything yourself. So I don't know. It's not a very fun story, but I still remember it.
Okay, my last question for you. I'm enjoying this interview and I wish I can make it 10 hours, but I don't want to take much time for your time. My last question for you. Knowing what you know now, what single piece of advice would you give a newly independent an orthopedic surgeon, whatever
Mm,
is his specialty?
yeah. Well, again, in the category of true confessions, I would say that if I had to do it all over again, I would have spent less time traveling, more time at home, more time with the kids, more time with my spouse. Um, and in a way, I feel like now that I'm retired and I'm having grandchildren, we have four grandchildren now, three in Colorado and one in Miami. I'm getting a second chance. And so I'm actually taking a bigger role, I think, in taking care of and teaching and spending time with my grandchildren than I did with my own children.
Mm-hmm.
So, God has given me a second chance to make up for previous mistakes. You can't undo the past, but, it is what it is. And, life is always throwing challenges at you. So, um, I think the single most important thing, it's important to be a good doctor, be a good, treat patients like you would treat your family, and to be kind. But it's very important also to set those limits and make sure that even if your life is compartmentalized, you have to have important time set aside for your spouse and for your children.
Perfect. Perfect.
They're going to grow up with you or without you, so you might as well be there and have some influence on them.
Yes, yes. Great advice. Great advice. Dr. Herzenberg, I'm honored to know you. I'm honored to learn from you. I like, for me, you are the first person always in my mind to ask for an advice because I know you are a humble person and you will give me an honest advice. Thank you for accepting the invitation for today. I know your schedule is busy, but thank you for accepting the invitation. I appreciate every moment and every second for this interview. Thank you, Doctor.
Thank you, Doreen. Thank you for inviting me. Our relationship as a mentor and mentee goes back 7 years now to 2019 when you were visiting resident, and it's really wonderful to see your career blossom and to see you do the fellowships you've done and starting. And now I know you're married. Congratulations on that.
Thank you.
And so it's, I hope your career continues to blossom. And to all the nameless, faceless people who I can't see who are on the webinar right now, good luck to all of you in your careers and Ramadan Mubarak.
Thank you. Thank you. Thank you. I can't thank you enough.
Okay.
Good,
All right.
good night. Thank
Good
you.
night. Okay.